If you are overweight, obese, pre-diabetic, or have type 2 diabetes, this protocol is for you. Only 12.2% of American adults are now metabolically healthy. 86 million adults in the US have pre-diabetes, and 70% of these individuals will eventually develop diabetes. Being overweight or obese is the main factor for progression to diabetes. The best way to reverse diabetes is to not get diabetes in the first place, because your chances of heart disease, cancer, and death are increased even as a pre-diabetic. Our protocol offers real hope and transformational change to patients who would otherwise be consigned to a lifetime of medications, doctor's visits, and suffering. Welcome to ReverseDiabetes.md.
Hi, I'm Dr. Gurpreet Pata. I'm a board-certified anesthesiologist, interventional pain physician, and addiction specialist. Today I'll be talking a little bit about one of our protocols that we utilize to help patients with obesity, prediabetes, and diabetes type 2. So I get questions all the time. Why are we so concerned about GGT in our clinic? And I view GGT as the oracle of death. It's the final common pathway for everything that's going to go wrong in your body. It's the final clearance pathway for your liver. And when your liver starts to get significant dysfunction, everything is going wrong. So I measure GGT, and I don't look at the reference values that are provided by my laboratory company, because the reference values include a whole host of patients that are already on their way to significant organ injury and death. And so I'm going to give you some references that we use and give you the references of why we use them. I really look at GGT as my crystal ball in what's going on with the patient's liver functions, and I'll explain why. Gamma-glutamyl transferase, it's an enzyme found in really high concentration in the liver. And every time you get liver damage, you see GGT going up. GGT catalyzes the transfer of gamma-glutamyl functional groups from molecules, such as glutathione. Glutathione is your reactive oxidase species vacuum pump. It quenches an ROS pathway. So every time that you have a significant oxidative stress, glutathione is there to clean it up. Glutathione removes free radicals, and it provides natural protection against oxidative stress. GGT reconstitutes glutathione. GGT is the only enzyme of the glutathione cycle located on the outer surface of the plasma membrane. So it faces the bloodstream. It faces the interstitial tissue. GGT allows glutathione to be recycled, and it's the thing that permits that recycling. It's the rate-limiting step for cysteine. And so in order to get more GSH, or glutathione, inside the cell, you have to have GGT. When glutathione is depleted, you get out of control oxidative stress, and you get tremendous DNA damage, you get irreversible cellular damage, you get scarring, you get tissue damage, and you get impairment of organ function. So when your GGT goes up, it means that you're utilizing much more glutathione than you were expecting. And there wasn't enough glutathione in the system to deal with some oxidative insult. And what's interesting to me is that whenever you have an oxidative insult, you have an immediate upregulation of GGT. So you get a tremendous rise in GGT just from the oxidative stress, and you get a rise in GGT because your glutathione is depleted. So it's a combination of factors that's making that GGT go up. Now, when GGT concentrations are above low normal range, it means that you have a significant issue. You want your GGT to be very, very low, because as it goes from that low normal and up, that means your glutathione is starting to get depleted. It's a dose response curve. There's not an actual cutoff, and that's the thing that people don't realize. They think that until the GGT gets in the 50s or 60s, it's not a big deal. But I'm going to demonstrate to you that it's a big deal up front. Glutathione depletion occurs with insulin resistance. If you take in too many carbohydrates, if you take too much food that's processed, too much vegetable oil, omega-6 vegetable oil, if you take in alcohol or other liver toxins, you create a reactive oxidase stress in the liver. And the liver starts to become insulin resistant. And as it becomes insulin resistant, you get increasing insulin levels. And as you get increasing insulin levels, you get more fat accumulation. As you get more fat accumulation, you become more insulin resistant. There's also, as you become insulin resistant, you get later elevated glucoses, and the elevated glucoses cause glycation of receptors. It causes glycation of cellular media, and you get advanced glycation end products, which also themselves cause damage to the cell walls. As fat accumulates in the liver becomes more insulin resistant, simultaneously undergoing significantly more stress and depleting the glutathione, and that's when the GGT starts to rise. So there's a whole host of things that can cause insulin resistance and damage and hyperinsulinemia. It could be simply some things such as low vitamin D, low vitamin K2, low magnesium. It could be things like a genetic pretendency. It could be excessive fructose consumption with primary deposition of fructose in the liver. It could be generalized glucose and fructose substitution. It could be too much omega-6 and not enough omega-3. Omega-6 is oxidized linoleic acid traditionally, and it creates a tremendous amount of scarring and a tremendous amount of damage because it's heavily oxidized. Omega-3 is usually not oxidized because its stench is so bad when it gets rancid with oxidation. All of this ends up leading to hyperinsulinemia, which eventually leads to atherogenic dyslipidemia. And what that means is simply that as you get all this garbage into your liver and you become hyperinsulinemic and you end up with a fatty liver, your triglycerides start to go up. Your oxidized LDL goes up. Your total ratio of oxidized LDL to HDL goes up in comparison because your HDL drops. And this combination is deadly. The clinical signs that you're going to see is whether they're thin or fat, you're going to see that their insulin levels go up. And later, you're going to see blood glucose is going up. And you probably will see, with the rising insulin, increasing blood pressure, because insulin is hyperinflammatory and it causes thickening of blood vessel wall, increasing stiffness, which will then increase diastolic and systolic blood pressure. Eventually, this leads to organ injury and death. Now, don't take my word for it. There's a lot of people that are super smart that try to figure out, how do people die? And these are the insurance actuaries. These are the people that are most interested on the survival statistics of people, because they actually have to pay out money if somebody dies early. So they figure out what are the things that are going to rapidly identify if somebody's going to die quickly. And they're looking at time horizons of 15, 20 years. So they're not looking at like next year. They're trying to figure out what are the early signals of death. And what they've concluded is that it's GGT. It's a very strong indicator of impending organ injury and death. They originally measured it because they wanted to see if people were lying about alcohol consumption on their life insurance applications. But then they realized that it was a more sensitive indicator of impending organ injury and death than anything else that they've got. And now GGT has become the central underwriting biomarker. They can figure out, based upon your level of GGT, how long we expect you to live. Elevated GGT historically was associated with liver dysfunction, most often from alcohol. There were some other drugs too, barbiturates, phenytoin, non-steroidals, including aspirin, St. John's wort, kava. Some of the other hepatotoxins were associated with GGT elevation. And that's why it was originally measured. We now believe that GGT is an early warning sign of other health risks: atherosclerosis, cerebrovascular accidents, type 2 diabetes, end-stage renal disease, cancer, metabolic syndrome, and most importantly, all-cause mortality. GGT does not have to be above laboratory normal to have an increased risk. When GGT concentrations exceed the lowest 25% of the normal population range, the disease risk grows proportionally. This is a dose-response curve. For every incremental increase in GGT, the all-cause mortality goes up. For every incremental increase in GGT, the hazard ratio goes up. So what's a normal GGT then? A normal low is for women less than 9 and for men 14. And keep in mind that the laboratory testing typically is 36 and 56 as high. But by the time that you get to these high levels, you have significant potential for organ injury and death. So really what I like to do is I like to keep my patients below 18 for women and below 28 for men. The lower I get it, the happier I am. Recognizing that even 18 and 28 may be too high and may be an indicator of disease. And we do everything we can to get that GGT down. GGT is a marker for us of what's going to happen in the next 15 years. GGT is your check engine light years before your car crash. It's your check engine light before your engine stops. They looked at the Framingham Offspring study, and only GGT reflected the high rate of advanced disease endpoint and mortality as an early indicator of metabolic syndrome, cardiovascular disease, heart failure, and all-cause mortality. GGT is a predictive value of future mortality. About 21% of men and 15.6% of women have elevated GGT. But elevated GGT, even within the normal laboratory ranges, is still an additional risk factor. So it could be 50 to 70% of the general population that has a moderately elevated GGT that's at significant risk. And we know now that statistically only about 12.2% of the US population is now metabolically healthy. And those are stats from 2019. So patients at the high end of a normal GGT have about a 1.5 increased risk of dying from cardiovascular disease in comparison to people with normal low GGT values. So that's a hazard ratio of 1.5. Now, if you compare it to the hazard ratio of an elevated LDL in somebody that has not had an MI, that hazard ratio of an elevated LDL compared to a normal LDL is 1.001. And this, we're talking with an elevated GGT of 1.5, is significantly greater. All-cause mortality and elevated GGT in the upper fifth of the population level leads to about a 2x increase for all-cause mortality, a 1.7x increase for cardiovascular death, and a 2.3x risk for cancer and death. Liver cancer in the upper fifth goes up 15 to 18. If you look at the hazard ratios and you look at the upper 20%, your hazard ratios all-cause mortality are over 2.0, and that's pretty significant. GGT above the reference range for women, greater than 9, or 14 for men, has a p-value of 0.001 associated with all-cause mortality, cancer, hepatobiliary cancer, and vascular mortality. And this is a pretty significant number. This is much more significant than when you look at LDL. Atherogenic dyslipidemia is a predictor of impending heart disease. Dyslipidemia is a reflection of insulin resistance. And when your liver becomes insulin resistant, it causes visceral fat accumulation in your organs. Visceral fat accumulation is typically seen as a larger than expected waist, a beer belly. Even a small one in women is significant. There's a lot of patients that we find that are slim, but they actually have a tremendous amount of visceral fat. They're what we call TOFI, thin on the outside, fat on the inside, and they have elevated GGT. But for the elevated GGT, we wouldn't know it, and then we would have to then obviously order the insulin and figure out if this patient is insulin resistant. And keep in mind that hemoglobin A1C can be normal in these people for a long period of time, but it's the hyperinsulinemia that's exposing them to the risk, which is then causing a change in the GGT because the liver is under tremendous stress. Dyslipidemia is a combination of high LDL, low HDL, high triglyceride, and high particle count of LDL. Atherogenic dyslipidemia. It's probably the main cause of essential hypertension. As you get hyperinsulinemia, your vessels get stiffer, they get thicker, and you can see this almost in real time if you look at carotid intimal studies. If you reverse their hypertension, you're going to have to do this by reducing insulin, because it's the root cause of why they're getting thicker blood vessels. That's the root cause of the stiffness. Giving them a beta blocker is going to treat a symptom, but it's not going to treat the cause. Giving them a calcium channel blocker is going to treat the symptom, but it's not going to treat the cause. My preference is to treat the cause. Certainly, there's times to treat the symptom until you can get to the cause, but it's a combination of things that you have to do. And my primary goal is to treat root causes rather than cover up symptoms. GGT closely correlates with atherosclerotic plaque formation. And in fact, when you look at atherosclerotic plaque and you look at the oxidized LDL in the plaque, you see that there's a ton of GGT right there. It's just flowing out and on top of the cells, and there's an increased concentration of GGT in that area. So there's a co-location of GGT and oxidized LDL. We look at GGT, as I said, as a marker of underlying liver disease. It's a marker of insulin resistance. It's a marker of increased oxidative stress. And we know, as I stated, that GGT co-locates with oxidized LDL in those atherosclerotic plaques. Now, if you have a low BMI and you have a low GGT, we'll assume the risk factor of 1. So you don't have an increased risk. If you have a low BMI, less than 25, and you have a high GGT, you have a 3x risk of diabetes. If you have moderately high BMI and a high GGT, you have a 15x risk of diabetes. If you have a high BMI and a high GGT in the top 1/4 of the population, you have a 19x risk of diabetes. So GGT is a major player in your next 3 to 5 year and even 7 and 10 year risk of diabetes and metabolic syndrome. GGT actually may be more predictive of future diabetes than weight alone. If you normalize for weight, GGT seems to be more predictive of diabetes and insulin resistance and liver inflammation than the obesity itself. And this may explain why there are some patients who are obese, rather exception to the rule, less than 20%, who do not get diabetes. It's probably because their GGT doesn't go up, because they're not under liver oxidative stress. Our treatment protocol for elevated GGT is to decompress the fat out of the liver. And that's using either a time-restricted feeding window or fasting. If I can get somebody to do a true fast, 3 to 5 days, we can flush out the liver. We can tremendously change the liver intercalated fat, and we can immediately change the insulin resistance in the liver. The other main factor is to change the ratio of omega-6 to omega-3, and we supplement heavily with omega-3, 4 to 6 grams a day. We encourage the patient to switch to all natural fats, get away from vegetable oils altogether. We encourage the patient to eliminate all processed foods, get away from the grains, get away from acellular carbohydrates, get away from fructose. We frequently use metformin to enhance insulin sensitivity in the liver. And we recommend coffee consumption or caffeine consumption because we've shown that caffeine consumption reduces GGT by reducing fatty liver. Again, it's a combination of factors that cause insulin resistance and hyperinsulinemia. There's a whole host of them, but the end result is a damaged liver with an atherogenic dyslipidemia, and the biomarker, the most common biomarker that we can see early, is GGT. GGT is the oracle of death, and it tells you what's going to happen in the next 3, 5, 10, 15 years. And what's cool about this is that it's fully reversible. We can fix most patients if we get to them in time.
This has been Dr. Pata with ReverseDiabetes.md. Remember, the information discussed should not be considered specific medical advice and does not constitute a physician-patient relationship. This field is extremely complex and requires a direct physician and patient interaction. Each patient is medically unique and the exact protocol will need to be tailored. If you need further assistance, call our office at 314-481-5000 or send us an email to info@reversediabetes.md.